Good evening, everyone. Welcome to our 44th virtual shadowing session, especially Spotlight in Orthopedic Surgery with Dr. Sonia Salone. If you have any questions regarding our program, please feel free to contact us at virtualshadowing@gmail.com or our Instagram at virtualshadowing. As always, these 1.5 hour to 2 hour sessions will be recorded and placed on our YouTube channel, Pre-Health Virtual Shadowing. Next slide, please. This program is brought to you by our wonderful working group comprised of Reagan, Cheyenne, Taylor, Elena, myself, Rachel, Ani, Miriam, Rohit, and our 4 physicians, Dr. Fowler, Dr. Morchetti, Dr. Salazar, and Dr. Reno. Next slide, please. We have lots of fun sessions coming up. We'll release the official calendar coming up soon, so stay tuned to our Instagram and our email for that. Next week, we have a PA spotlight in oncology. The following week, we have a PA spotlight in psychiatry. And then the following week after that, we have a specialty spotlight in radiology. All those sessions will be on Zoom and YouTube Live at 7 p.m. Central Standard Time. Speaking of upcoming sessions, we have a quick announcement from Dr. Salazar. Next slide, please. Dr. Salazar.
Hey everybody, good evening. And Cheyenne, if we could queue up the little video right quick, would that be possible? Just wanted, while we get that rocking and rolling, just a reminder that we will have our 3rd episode virtual clinical observation program this Thursday, April 1st, 7 p.m. Central Standard Time. It's going to be featuring my father and his medical journey from his little scared with death back in December. Lots of pictures, videos, ultrasounds. It's going to be a phenomenal one. A reminder that all the links for registrations are in my bio on Instagram. I'll put it on the chat. And our website is www.vcop.ws. And look forward to our podcast, which is going to be coming up in mid-April. And that one's going to be on whether medical missions are really worth it. Here's a little teaser of one of the sessions we're working on. So hope you enjoy it.
Mr. Palma, how's the airway on top? Is he moving air?
Airway's intact.
Is he any symptoms airways or anything else?
He's got such a lot of bilateral layers, no hemopneus, no nasal. That's what he was
All right, let's get our chest x-ray, please. All right, standing your chest x-ray right there.
No obvious fractures here.
Okay, all right.
Did you walk after the accident at all? Not sure. I would also get a pelvic.
All right, let's go. Tell me to get straight and fast, please.
Okay, that's a little taste of what's coming in one of our pediatric focus sessions. So hope you guys can join us. If you have any questions, put it in the chat, Instagram, or you can reach us at on our website. Thank you.
Thank you. Dr. Salone, can you screen share again, please?
Yeah, I sure can. All right, and we are up. Can you see that one?
Yes, beautiful. If y'all have any questions for our physicians or Dr. Salone, please put it in the chat as we go along. Please do not DM any of us. The virtual shadowing team and I will be collecting all the questions and we'll ask them during the 2 designated Q&A sections, one at the middle, one at the very end. And for the assessment, we'll show y'all the QR code for this week's assessment at the very end after the last Q&A. So stay tuned for that. We'll also send that out via email, on our website, and on Instagram. Without further ado, next slide, I have the honor of introducing our beautiful speaker tonight. She is not only a force to be reckoned with in the orthopedic surgery world, she is also a leader in the medical community. She's a leader in her religious community. She's an author, a philanthropist that helps women and minorities in STEM careers, and overall an amazing woman. I have the honor of introducing you guys to Dr. Sonia Salone. Please give her a warm welcome.
Hi guys, it's an honor to be here tonight. I think you guys, I have almost 500 people on here and you are privileged to be part of this virtual shadowing group. I mean, in this middle of this whole COVID pandemic and the medical world has been brought to our knees, what has happened to our students has been not so great. So pre-med, med, master's degrees, practicing, in some field of medicine, be it nursing or whatever else, this program is phenomenal. I haven't seen anything like this. And so when I was approached, I was just blown away that I wanted to definitely be part of this. So, we have this thing, especially with COVID, and they're talking about superheroes and everything else. It's like, I don't think we're necessarily superheroes, but we do have a few superpowers. And so I just happen to be a surgeon. I use power tools to do what I do. And I love being an orthopedic surgeon. So the question is, do you actually guys know what an orthopedic surgeon is? Because I'm asked all the time. So a lot of people will say, oh, that's a foot doctor. No, that's a podiatrist. Oh, you're a dentist. No, that's an orthodontist. So orthopedic surgeon by definition is dealing with disorders of the musculoskeletal. So your muscles, your bones, your joints, specifically spine and any of the deformities that happen due to trauma or accidents or injuries. That's what I do. That's what I take care of. So I deal with broken people for a living. This phenomenal little boy was a patient I took care of at Shriners Hospital during my training at Baylor College of Medicine. And his family, literally the whole family, there was 3 brothers, and they all had this genetic disorder that they came over from Mexico. And they lived at Shriners Hospital for almost 3 months while they were surgically corrected and manipulated. And then they were sent back and then brought back again for multiple surgeries over the years of my training. But it was delight. And so this was ideal because also when you think of ortho and you think of peds, ortho, bone, peds, pediatric, we try to change some of the things that may be misshapen or not aligned correctly at a young age because we grow. So interesting fact, just a great family and Shriners Hospital, I would always give back to them.
So Sonia, this is Fowler. Have you been able to establish long-term relationships with some of your patients lasting over the many years?
Yeah, people find you on social media, which is amazing sometimes. Sometimes can be scary, but I have had patients, usually the younger patients, but some of my older patients as well. With me doing contract and traveling a physician, I deal with so many different populations and different people that sometimes they just want to let me know how they're doing. Others now have actually reached out on telemedicine. So I've had a patient that came back for specifically, she had thoracic outlet syndrome and had the rib removed and so starting to have shoulder problems and wanted to know just, what I had done surgically and that kind of thing. Now, did I remember that? I'm not sure, but it was more of a just impressed that she found me, So yeah, it's pretty cool now with technology, definitely. So I
spent the first year in a surgery residency before I turned to emergency medicine. And I realized that in surgery, once you cut on somebody, you have a relationship with them forever.
A binding relationship. And that's a privilege, though. That's something we should definitely say, what I do, some people may think is gruesome, but at the same time, it is very much intentional on trying to fix and repair people. And it's not always an easy field to go into, but people are usually so changed. Their lives are changed for the better if we can fix and repair and do things our job correctly. So with orthopedics right now, there's approximately 30,000 in the country practicing orthopedics right now. So it seems like there's not a lot, but 30,000 practicing orthopods, 94% are males.
Wow.
So let me sink that in one more time. 94% are men. And that means that the 6%, and we call ourselves that, the 6% of women that are in ortho, it's a boys club still. And things are starting to change a little bit. And you guys know that this is the one of the final days of, Women's History Month and that kind of thing. So it's phenomenal to see the change occurring and being part of that change. The number of African Americans specifically, because I am Black, is less than 1.5% in the country. And that means...
So Sonia, we've already got an interesting question. Do you think that there's an intimidating or a competitive culture that makes it challenging to be a surgery resident? What do you think?
Oh my God, yeah. You know that. After being in general surgery, this is very much a club. You're definitely harassed. You're definitely... initiated, if you will. And so not everyone is built for that. Not everyone is built for that or that mentality, but it's lifestyle, and so we'll talk about some of that later on about lifestyle of what you're willing to tolerate and how long you're willing to tolerate that. But it is considered a boys club. It is one of the final frontiers as far as the number of females in orthopedics. There's more neurosurgeons and cardiothoracic surgeons that are women than in orthopedics.
Interesting. So our friend Jillian, one of our students tonight, are over 500 that are listening to you. She says, what's it like becoming successful in such a male-dominated field? Are you our hero? Are you our cultural hero?
That's the superpower. Yeah, being a black woman, a black woman in orthopedic surgeries. That's the BWOS. You see the less than 0.8. There's only like 80 of us in the country. There's less than 80 of us in the country. And so recently with the match last week, we had like 17, new people that are going to be going into orthopedics that are black women orthopedic surgeons. So yeah, there is some heroic, heroine type of phenomenon going on that I'm proud of, but don't get it twisted. I mean, it was a hard road. I mean, it was definitely taxing on my energy, my spirit, my heart to get through, but it's also so I can see more come this way. And case in point, to be here tonight, I want you guys to be informed about orthopedic surgery, that it's a great field to go into.
I wish you could see the comments coming through. You've just been called a queen. Wow, awesome. Please continue.
I appreciate that. So let's talk about this. What's this journey going to do? How long is it going to take for you to become an orthopedic surgeon? So if I give you little cues of like, maybe that may be a question later on, you want to pay attention. So let's add up the cost. How many years does it take to be an orthopedic surgeon? So I was a chemistry major at Texas Tech University, 90 to 94, 4 years of college to get a bachelor's in science and chemistry. Now, during my reign there, I was nominated to be part of the homecoming court. And because Texas Tech was predominantly white, 25,000 students, and the Black student population was less than 1%. My hometown was only 23,000 people, you guys. So Texas Tech was bigger than my hometown. Had no idea that I would ever be able to win this prestigious moment of becoming homecoming queen. So you said crown. I do have a crown, So 4 years, college. Some people may take the scenic route. So you're going to be the scenic route and do 5 years. Okay, understand. Master's degree, 6 years. And then you go to school, 4 years for medical school. And I went to UTMB in Galveston, medical branch in Galveston from 95 to 99. And this building is called Old Red. It is one of the oldest buildings in Texas that still stands. It has survived numerous hurricanes, including the hurricane of 1900s that devastated the coastline of Texas. But you see, we had a very diverse class. It was almost 40% of minorities, and that was in 95 to 99. So it was actually a great place to be. I love Texas Tech. But 4 years of going to medical school on an island is not quite what you think, because it's still a lot of work. So remember, we've got 4 years of college. Now we're up to 4 years of medical school, but you're an MD now. They call you doctor, even though you don't know what the hell is going on. You don't know what you're doing yet. They do call you doctor. Okay.
So how was the weather down there, Sonia? Was it kind of humid, or what was it?
Oh, I mean, you have good days and bad days. It's definitely Houston type of weather. Some days it's going to rain around 4 or 5 o'clock, and then other days it's 70 degrees, 80 degrees in December. So you just never know what you're going to get. In Texas, as they say, wait long enough, it'll change. We have definitely diverse. Mm-hmm.
Sonia, I put in a gimme from the chat group, and I said, let's all say we love Dr. Sloan. And about 100 people just responded, we love Dr. Sloan. So.
I love being here. This is a great group to be able to pour into. I appreciate the honor to be here.
Please go on.
We're up to residency now. So for you guys that don't understand, you go to college, then you get into medical school. So those are your pre-med. You guys are pre-med, you still need to do a major. And then you get into your medical school. But while you're in medical school, you're trying to figure out what you want to do with the rest of your life. So your residency is what we call it, is what you do, your specialty, what you're going to go into. And so orthopedic surgery residency is a very hard place to get into as well. And part of your residency, you have to do 1 year of general surgery, because essentially you never know what you're going to be doing while you're operating orthopedics, that you may have to know some general surgery as well. There's times you have to take care of a blood vessel or a nerve and, all these different things that definitely general surgery helps with. So you do 1 year of general surgery internship. I chose to do a year of ortho research. So the orthopedics research is different than what you guys would be doing pre-medical school or while you're in medical school. This is specifically geared towards orthopedics. And I'll tell you a little bit more about that and what you guys should probably be looking at. And then you got 4 years of orthopedic surgical residency. Now this is like your first year, you're almost an intern in ortho again. So you're learning to splint, you're doing reductions in the ER. Dr. Fowler, I'm sure you've definitely had to deal with a lot in Salazar, some patient residents that didn't know what they were doing, or they were the interns learning to do reductions and that kind of stuff. So this is where you start learning your intern year of ortho. Your second and third year, you're honing in on different fields. So you may do 3 months on joints and learning how to do a knee replacement, a hip replacement, a shoulder replacement. You may just do foot and ankle. So you're learning the clinical indications as well as the surgical things to do. So they're broken up in different segments. We did some time at MD Anderson about tumor oncology. We did some time at Texas Children's Hospital learning orthopedic pediatrics. And then I told you about Shriners. So Baylor College of Medicine for me was the most diverse training that you could definitely get. And after your ortho year, you can do a year of subspecialty, like in your fellowship. So you can be an orthopedic surgeon and then you want to do just foot and ankle. You can be orthopedic surgeon, you just want to do just sports or spine. So that's an extra year. So these are the years: 4 years of college, 4 years of medical school, a year of general surgery, we're up to 9, 4 years of orthopedic residency, 13 years. If you do a year of research like I did, 14 years. And if you do a fellowship, I did not do a fellowship, I'm a general orthopedic, you're up to 15 years.
Sonia, this group that we're looking at, was this the general surgery intern group? Or
this is my graduating class, and you can see how diverse we are. I'm the only female. The female that's in the very back, Selena Poon, was still a surgery intern. She had not come in. So as you can see, I was with all guys. I was the only woman.
So there were 2 African Americans. There were 3, it looks like, Middle Eastern, or 4 possibly. About a third females, or maybe 4th females, and the rest Caucasians.
There's only one male, Ray. I'm the only female, and then the one that's in the very back, she was general surgery.
Oh,
so, yeah.
I see. So these limitations stay with us. Just reflecting upon the current match that we just had.
Yeah.
How hard it is to find African Americans who want to come to Texas. I mean, in just being candid about it, Sonia. So I would love to hear you talk some about how to span the range of diversity and ethnicity as we go forward.
Yeah, I talked recently, I did a couple of articles for MedPage, speaking about the gender bias in medicine in general, but definitely in the surgical field. And so what we're looking at is generations of people that are in positions of power that get to choose these, applicants, like yourself being the person that's going to decide who's coming in. It's like, is there any type of conscious bias or unconscious bias that may be there? In the surgical field, there's definitely still some bias there. In the Deep South, you better believe there's still some bias there. Are we slowly changing? I do believe so. One of the limitations that I feel is the fact that we don't have a lot of minorities that go back into academics. It's still less than 2%. They go back to academic medicine. So you don't have many African Americans and or Asians and or Hispanics that go back into academic medicine that could possibly be on these boards that make the decision of the residents or the medical students and residents that are coming into to play. And so that's part of it. It's a lifestyle thing of, do I want to go back and do academic medicine and get paid less and have to do more work? And you know what I'm saying? So it's
Absolutely.
A lifestyle choice. It's a lifestyle choice. And that's one of the limiting factors, I do believe.
What a great discussion. It touches on so many important issues. I mean, face forward right now, the front cover of all major journals in America today has to do with this issue of disparities and ethnicities and sensitivity to culture. And we have so much to learn on this. I'm on the admissions committee at Southwestern. Are we not accepting them? Or are they, Sonia, not accepting us? I don't know the answer to that, to be candid.
I think it's both, because you also see a resurgence in the HBCUs, in which you guys may not know what that is, historically Black colleges and universities. So things like Morehouse Medical College, Howard Medical College, University Medical College, Xavier, there's several others, Meharry, that are historically Black, because at one point, African Americans could not go to white medical schools. And so they built their own and they educated their own. And so now, with this current racial divide in our country, there has been a resurgence of more applicants applying to the HBCUs, historically Black colleges and universities, and the medical schools, because it's a take care of our own, as well as make sure that you have what you need and not be challenged. One of the facts that we'll talk about, I can bring it up here, is a lot of people don't understand the actual retention rate for orthopedic surgery and other residency. And the ACGME, which will be releasing this information later on, we had a discussion in the fall that basically said almost 40% of the African Americans that are admitted into orthopedic surgery residency are let go or fired before they finish. Hispanics, also more than 30%. And it started with orthopedics being the highest, and then internal medicine, and then anesthesiology. And these are more than 30% are let go during their residency. And no one really can talk about why.
There's a big cultural aspect.
Go ahead, Gil. I'm sorry.
There's a big cultural aspect to choosing a specialty when you're a member of an underrepresented minority. I was telling in the chat, our students, that my entire mom's family, they're all orthopedic surgeons in Guatemala. When I came to the US and I was looking at potential specialties, I'm looking at kind of orthopedic surgery, white male dominated type of specialty. And then I look at emergency medicine, where quite a few folks, Latinos, Blacks, a far bigger proportion. So right to your point, I think probably applicants are kind of making those choices, and they're going towards fields that specialties of where they see folks who look just like them. So there's a little bit of a big cultural component to all of this.
Yeah, and I think it's diversifying, Dr. Fowler. I believe it is changing, but it's slowly. This is a generational thing. I don't believe it's going to happen overnight. And like what I just said, it takes approximately 13 to 15 years to make an orthopod, to make an orthopedic surgeon. So in that time span, that's one generation. So therefore, with the changing of academics and academic medicine, as well as the influence through programs like this, shadowing and mentoring and social media, having more visibility for mentors, I think things will slowly change, but I may not see a huge number in my lifetime, unfortunately.
Sonia, I'm an old man in medicine. I'm approaching 70. I've been in medicine almost 50 years. I'm on the admissions committee. I interview for emergency medicine residencies, for faculty spots, and so forth. And I'm trying to learn about what I don't know about humanity, and about how to encourage the breadth of all of our diversity to try to come to our school. And I think that as I get older, I don't know how to do that. And I would love encouraging words from you about how to do that.
I think you're doing it. This program is a huge example of that. You're making it accessible, because what we don't have a lot of times is just the access to people that can make a difference and or influence their lives. And so we have something in our Black Women's Orthopedic Surgeon group, and Dr. Ida Brown, the president, is actually on tonight watching. It's basically about exposure. It's about mentorship. It's about having someone support you. And so a lot of times, I think as pre-med students coming in, you're consumed with MCAT scores and getting the letters and, maybe doing some shadowing and all this other stuff. And when realistically, your influence, where did it come from? Like me personally, it was an injury. I was hurt and, I got into orthopedics because of the doctor that took care of me. And if it would not have been for his kind words, I don't know if I would have been there. Growing up, I never saw a Black doctor. I never saw a female doctor in my hometown of Denison, Texas, North Texas, and so how does that influence someone and what they're going to do in life? And then even the expectations of feeling of almost like an imposter syndrome. I don't belong because this is not something I ever saw. Dr. Salazar said everyone in his family is an orthopod. I mean, that's phenomenal to me, but what I see and what I know and the hell I've caught to just get to where I am would have made a huge difference in just having the mentors and the people along the way to support. So I think you're doing that with this platform and have a listening ear.
I think the biggest secret to making sure the future of medicine is bright and diverse is working on the pipeline. That's what we're working on here now, encouraging people who look different than other folks, who don't have come from wealthy families, etc. People just like me. Working on the pipeline is the biggest secret. I don't think we understood that, and that's probably one of the biggest blessings from COVID is the ability to reach out all over the world and work on the pipeline. That's what we're doing.
Yeah. And we stopped calling it the pipeline in orthopedics, and now we're calling it the path. Because, pipeline really means it narrows down, right? So we're saying the path. If I can onboard more people on the path earlier in life, so that's why I have Sloan STEM, that's the whole thing of giving earlier exposure that they may have the notion to do this, or it's a possibility. With the Black Women Orthopedic Surgery Group, we partner with Nth Dimensions, which this is a pre-med level and medical school level. We also with the Gladden Society, that's on a pre-med medical school level. And then you have other organizations, but again, like Perry Initiative is another great organization for women in orthopedics or engineering that they start in middle school now, giving them exposure to programs that may get them on board to this path to orthopedic surgery. But it's gonna take a village. It's gonna take a village. And again, Dr. Fowler, I'm 50 and I may not see it in my lifetime. I may not, but we're doing something now about it. That's what we're doing.
Well, Sonia, first, if you're 50, you look like a teenager. So, and I'm pushing 70 really hard. So I'm at the far end I'm in the autumn of my career. We've interrupted so much, and I wish you could see the questions pouring into chat about so many things, but let's let you stay on point to your principal message, and we're going to keep hitting at you from all ends. Okay, go ahead.
So one of the things that I believe in is definitely research. One of the way that Dr. Salazar is saying is that you've got to be able to play the game. I've written this book called The Rules of Medicine. I definitely tell you guys to get a copy of it, but part of playing the game is, knowing what you have to do to get to the place that you want to get. And so part of that is research in orthopedic surgery. It doesn't have to be a category or category one type of research. It can be a paper, a review article. It can be, a composition of meta-analysis of multiple papers that have come together, that kind of thing. This was one of my papers that I wrote. I know it's sort of blurry. It's called the coracoaclavicular reconstruction on the lateral half of the conjoined tendon. Let me break it down. Shoulder, AC separations, athletes, they can tear the ligaments between those two areas and we have to fix it. And so this is one of the ways that we can fix it using their own body, their own parts. But I was able to get this paper finished before I finished my residency and it was published, which made a huge difference because I did run into some very racist situations. I ran into faculty members that did not want me to finish, that literally blatantly asked me to leave. I had great other mentors and faculty members that were on my side that pushed, that helped me get this paper written and everything else. And it helped to navigate the system to basically said, I was the only resident that was published before we finished. And so that really, really helped. I also did a research paper with NASA. My year I was doing research that basically was the International Space Station the iRed, which is the intermittent resistant exercise device. And it looks like a treadmill with wooden slats, essentially, up in space. And it's tied with a coil that basically sort of unwind and wind. It's attached to a harness. And so my research project was the harness, that we looked at different types of harness. And I love NASA, I love all things space, but it goes to the lowest bidder, the lowest contractor, to what is going to actually go up in space. And so this was like literally football pads strapped in that attached to this harness that they did squats or they walked on the treadmill, you know? And so we looked at the EMG and the nerve conduction velocity test to see which muscles were activated more with different types of harnesses. And we were able to publish the study, and NASA had to pull the article because, now I can say it, Schwinn, the bicycle company, owned the coils that were up in space. But the new company that had the harness wanted their own coils, which means they would have to be replaced. And so we could not release the proprietary methods of this new vest or whatnot on this harness. And so it became logistics and everything else, but the research was phenomenal. And I had this great experience at NASA for about 6 months doing this research. So
Sonia, I'm looking at this paper that you wrote. Is that from the conjoined tendon? Is that the?
Mm-hmm.
So the corticoclavicular ligaments are the strong ligaments of the AC joint. And so what you found, your discovery here, was that the reconstruction of the strong ligaments of the AC joint was using the conjoined tendon. This is actually a very important piece of research. So what did this study do for you so far?
I mean, basically, I've used it a couple of times. It's basically being able to go in and actually harness it and reconstruct it. The weak element to this was the actual suture that we use. Fiber wire is what we use, is where it would usually break with our reconstruction. So we potted the shoulders, we did the harness pull, and with almost 4 times the force, this never failed compared to the screw technique or the reconstruction with another ligament, other type of allografts, that kind of thing. So this was phenomenal. It was a great study.
One of the chief problems in emergency medicine, and for the last 20 years, I've been with the residency here at Southwestern, is to get the kids to understand the anatomy and physiology of what they treat every day. For example, something as relatively simple as an AC, acromioclavicular separation, is actually fairly complex anatomy.
Yeah.
You have to kind of understand the anatomy. And what you've pointed out here on this, what seems to be somewhat erudite study, is in fact that you've dealt with the principal issue of the problem.
Yeah.
Which is to rebuild the strong element of the joint that got separated.
And I love this because it was actually anatomy. And we actually, because I was a year in research, I actually went in and harvested these shoulders. So that was part of the research. So if Baylor College of Medicine called and they had a fresh body, we would actually go in and harvest all the joints for research. So that meant if there was an ankle, we did a disartic at the knee, hip, and spine, as well as the AC at the C1, C2 area. So it was very interesting to do a year of research.
Yeah, I hope the students understand what you just said, which is that when there was a cadaver, a dead body that was donated to the medical school, that they would call you in to be able to dissect the areas of your interest.
Yeah.
Which is,
and it's not all, it's gruesome, but it was great for, again, anatomy, physiology, in training, to see it and not be at risk for hurting something, if you will.
Absolutely.
I would definitely do the research, to do a research project if you can, yes. And how would you navigate that as a pre-med student? You want to try to get with a faculty member, and it may not necessarily be in orthopedics or the field that you're going into, but there's so many things out there that you could look at and or do a chart review and or that kind of thing. But you want to get your name on it, on an article or a publication. It could be a chapter in a book or whatever else. And so you basically are maybe doing the scut work of just finding that data and pulling those numbers and putting them in Excel sheets, data sheets or whatever. But it can get your name on a publication, which is huge and will change.
Yeah, Sonia, one of the things that strikes me is that early on, over 40 years ago, I started learning the anatomy of what I did, the bones of the wrist, the bones of the foot, the bones of the ankle, and so forth. especially because I had to interpret the plain films myself this 30 and 40 years ago. It strikes me that the kids of today, and kids, as all of our students know is a compliment, seem to be somewhat less interested in learning the anatomy of these things. Do you see that also, or is that just in my world?
I think it's not as important with technology now. You know, there's so many apps with the anatomy layovers and different books and that kind of thing. I think it's still a hands-on, especially if you're going into a surgical field, you know, in ER medicine as well, because there's so many times you're looking at the bone, and, you know, there's a flap of muscle and you don't know if it's the ECRB or if the flexor pollicis longus or, you know, whatever it is, but you've got to know the anatomy to be able to take care of people. So that's why it's one of the first courses you take. You've got to know it. You've got to learn it. You got to love it. I mean, this is what you're going to be doing for the rest of your life, taking care of people's bodies. So you got to love it.
So is it possible to actually develop a passion for understanding anatomy, do you think?
Nah, but I think a respect.
A respect, not a passion. Okay, there we are. There we are. Oh, that's good.
So out of orthopedic surgery, there are the residency program. So now you finish medical school and you're going into orthopedic surgery. You've gone through this thing called the match, and you get into one of the 150 accredited orthopedic surgery residency spots in the country. They only take 3,000 total. 3,000 total national residency spots, and there's 610 each year. So this year we have 610 new ortho residents that will be starting as interns. So it's a limited number. It's a very limited number, and it's like threading a needle to get you to that point. So you've got to be laser focused and targeted on what you want. And I think passion definitely plays into that. So I was trying to be a little funny here with, you know, do you know what other subspecialties there are in orthopedic surgery? First of all, let's talk about how many of you guys know what bone this is? I'm showing you a bone, the top part and the bottom part.
Well, I just know that that's got to hurt really.
Exactly. So this is, we could talk about the
subspecialty. Where the femur has broken off.
Multiple fragments, yeah. So the picture, the image on the left is a partial hip replacement. So you're looking at the femur. What we do during joint replacement or partial, this is due to trauma, we take off the actual femoral head, the ball, if you will, of the socket, and then we actually put a stem in and a new ball. And so that's what you're looking at on the left. Now on the right, this patient basically fell and broke below that stem at the knee, and they shattered it. And so you're looking at the right image, the distal femur is very comminuted, or what we call shattered. They broke the hell out of it. So it's in lots and lots of pieces, and figuring out how you're going to do that. And usually what happens is as you pull on it, it will line up a little bit better because of some of the lining of the bone or the periosteum. So it's a bad fracture, bad injury, and makes it worse with knowing they have this joint replacement. So the different types of subspecialties, and you guys can just think, start from your neck and go all the way down. So if we're going to do, let's see here, we'll start hands, okay? The different subspecialties. This means after you finish your residency, you're going to do a special year of training fellowship in one of these specialties. Hand, which is very difficult. It may seem so simple, but there's so many moving pieces to the hand that is just phenomenal, very intimidating. Adult hip and knee. So like what you just saw, the x-ray would be for a hip replacement, knee replacement, that kind of thing. Shoulder and elbow go together. Trauma with Dr. Salazar and Dr. Fowler all the time. And this is basically in orthopedics, the high moving car accidents, gunshot wounds, it can be stab wounds. I've had bow and arrows through bones, chainsaws through bones, you know, that kind of thing. So anything that is going to break a bone or traumatize the bone. Sports medicine. So like my research paper was in shoulder, specifically the AC joint. You got knee, like ACL, you got ankle injuries. So sports medicine does cover a large gamut, but specifically with athletes. Spine surgery is very specialized in orthopedics. We do a lot of implants and fusions and that kind of stuff. And it's a shared field with neurosurgery on different levels. So just because someone says they're a spine surgeon doesn't mean they're orthopod. They could be a neurosurgeon too. So those are some of the shared fields. Pediatric orthopedics is a subspecialty because kids are definitely treated differently. They have different ages that we have to worry about growth plates closing, and how angulations have to be fixed at certain ages of what we can and can't tolerate. And then as well as the metabolic issues and some of the genetic issues. So pediatric orthopedics is its own world all by itself. Then you have foot and ankle and tumor, musculoskeletal oncology. These are the subspecialties of orthopedic surgery that you can specialize. I'm a general orthopod. I sort of cover the gamut of these, especially someplace like Navajo Nation. I deal with a lot of these things. We're level 3 trauma and we ship a lot of out, but usually before they ship out, I'm acting as a level 1 trauma, and training at Baylor has taught me how to do that. So I'm not intimidated. However, I don't want to put a halo on a patient at 2 a.m. on a Navajo Nation and try to put them on a helicopter. So therefore, we try to send things out very, very quickly, if you will.
Dr. Sloan, my aunt in Guatemala is orthopedic surgeon with a subspecialty in hands. Interestingly enough, I didn't know any of this until I got a little bit older, but she is a left hand subspecialist. And so it was amazing to me whenever I was thinking about specialties, and I'm like, wow, you become really, really specialized when you're specialties.
Wait a minute. She specializes in the left hand. Come on.
Yeah.
No.
Yeah.
I don't know how much of the anatomy changes that much, but that is definitely specialized.
Yep.
Yeah.
And
Dr. Salazar, I actually was part of, and I am, and Dr. Ide, who's on too, this international global women orthopods were part of this. And so the South America had their own international thing that I spoke on. It's Orthopedic Phenomena. And so they basically just had a whole session, and these women were phenomenal. Like what they're doing just blew me away as well. But they had definitely had to still deal with the male gender aspect as well as the whole thing of women shouldn't be in certain places. So it was definitely worse in South America than what I have experienced here, and or maybe just under different covers, if you will.
Most definitely, with much less awareness to gender bias, in our countries. So yeah, definitely pioneers in y'all's field for sure.
Yeah. All right, so let's get down to it. What everybody wants to know. Where's the money? Show me the money. So orthopedic surgery is one of the top paid fields in medicine. If you broke it down, the average is about $400,000. Someone that is literally living in the hospital, never go home, and they never see their family, and they don't have a life, they may be making that upper end of 600 plus. But lifestyle definitely categorizes what you're doing, how much you're going to do, and how long you're going to do that. In different fields as well. Spine definitely makes more. Joints is going to be making a little bit more, as well as sports making possibly more. But again, it depends on how many patients you're seeing, how many surgeries you're doing, that kind of thing. But again, I come back to lifestyle. So I'm a contract physician. I have been working with a company called Comp Health for years as a locum tenens, because when I came out of medical school after that 14 years that we talked about earlier, had got pregnant, wanted to have a family, and was told I possibly couldn't, had a difficulty getting pregnant. So it became very important for me to have a family at that point. So I chose contract work because then I could delegate my schedule. So I'm closer to the 25%, the over 280 a year, but I only work about 8 days out of the month, and so in doing that, I chose the lifestyle I wanted, because then I have a nonprofit, I have other businesses, I have, my husband's a pastor of a church, so I do so many other things. Now is a time that you can sort of pick and choose the lifestyle that you want once you get on the other side, but you got to get to the other side.
Sonia, I wish you could see all the things that are popping into chat, which is wow and smart and impressive. We want to hear so much more about this.
Yeah, this is impressive, but again, I want you to understand everything has a price. And so when I say that, lifestyle is very, very important now with burnout from COVID and from doctors wanting to spend more time with their families and travel and that kind of stuff. It definitely plays into what field you go into in medicine, as well as the level of what you're willing to do in medicine. I.e., I couldn't do 25% as an academic doctor. I couldn't be 25%. It had to be 50 or plus, you know. If I was at the 75 to 100% mark, again, I wouldn't see my family now. I'd probably be divorced and my kids wouldn't even know me. Those are the 14-hour days. That's the 14, 16-hour days. That's the 7 days a week. That's you are living, breathing this all the time, you know? So
you've really straddled it. I did private practice here in my hometown in Georgia, where I am at the moment, for 20 years, where I was all private practice. And then I moved 100% to an academic practice for the last 20 years.
Yeah.
You've sort of straddled this where you do some private and nonprofit and so forth.
Yeah, I have.
Very, very clever.
But it was not widely accepted, you know? So as a woman coming out, it was, you go into practice. You get go join a group and you go in and you're low man on the totem pole and you're Q3. And I'm like, well, hell, this is residency all over again. What am I doing? You know? And so I bailed out before the 1-year contract was up and I had to pay all the money back on the guarantee, you know, and said, there's gotta be a better way. There's gotta be a better lifestyle. And so
Sonia, I hope that before you finish up in the next hour or so, and please talk as long as you want. You've got 600 people listening to you, sitting on the edge of their chairs at the moment, about how you structured this somewhat unique way that you practice medicine. We'd like to hear more about that.
Yeah, I definitely think it was, my husband plays a huge part of that. I mean, as a pastor of a mega church here in Houston, I have a great lifestyle, you know, as well, that makes me a little bit more comfortable, that I don't have to make as much, but even by yourself, you still, you know, have a great salary, but you have to choose what you want to do. And I believe that y'all are at a pivotal time in history where you can almost dictate what you're going to do and how you're going to do it. And even with locums and contract, people are able to pick and choose a little bit better than what we did 20 years ago. You know, when I came out.
Did you tell me a while ago that you had not a lot of debt when you finished school?
I didn't say that. I didn't say that.
Oh, I'm sorry. I'm sorry. I misunderstood.
No,
so
I came out of undergrad, no debt. And I went to medical school. My dad was a disabled vet, so I got partial payment through medical school. But, you know, I still took everything out because my parents my mom was a, you know, nurse. My stepdad was a blue collar. They just didn't have it and they couldn't give it to me. So it was on me. It was definitely on me. So about 100,000, you know, 100,000, but I didn't have any undergrad debt at all. So.
Well, that's still pretty good considering what happens these days, $200,000 and $300,000 of debt or even more. So.
Yeah.
So it sounds like you played that very wise along the way.
I did. I think at this point, though, again, lifestyle is something you need to consider about which field you're going into. You know, ER medicine has been scrutinized because there's a lot of burnout. But I think there's some flexibility now, and like Dr. Fowler and Dr. Salazar, you guys can see the differences of their practices and what they've done. And like you said, Dr. Fowler, you sort of lived 2 different lives, you know, being academic now and private, you know, earlier. And who's to say I won't go into full practice later on? I don't know, but right now I like what I do and the choices I have. And so there's sacrifices that you make. You know, I have this saying, you can't have it all, you know, because for women, they always say, oh, you can't have it all. And I said, you can have it all. It comes at different phases and different times in your life. And so therefore, you know, I did residency, I did the training, I did the hard thing, but then kids came after that. And then with the kids, I couldn't necessarily have the full-time practice, but I had something better because I constructed exactly what was good for me and my kids, you know, kind of thing. So different phases.
Yeah, Sonia, that's tremendous, and we're gonna get into that. And thank you so much. What a wonderful talk so far. We've already arrived at our first question and answer. We've got over 30 questions, which we're not going to ask you all those. Bless your heart. Rachel, do you want to take it away and let's probe the mind of Dr. Sloan a little bit?
All right, let's go.
There are so many good questions. The first question is, what is the difference between a contract physician and a non-contract physician?
So for business purposes, let's talk business purposes first. And this may be the best piece of advice I ever give you. As you become a medical student, and definitely before you become a resident, you need to have your own business, your own LLC or your own S Corp. And that is for tax purposes, but also for private protection entity of your separation of your home and your family, goods, money, and then your business. So I have an LLC. Now, as that LLC, that business can contract out with anyone on my terms. So the contract is basically me. I am the contract. I'm contracting out as an orthopedic surgeon. I work with companies that become a liaison between me and a hospital, and that's considered locums. And so with that contract, I tell them how long I want to go, how much I want to get paid, and then basically terms and agreements. And they work those details out. I'm not in it. I'm out of it. So contractor is basically your business of who you are, your entity. So I can't contract out as Sonia Sloan, but I can be Sonia Sloan MD PLLC, my professional limited liability corporation. That's a business entity, and that helps tremendously on your taxes each year.
Oh, gotcha. Wow, that sounds amazing. A lot of students are in love with your honesty and your personality. Some students are like, oh my gosh, she's the most amazing woman I've ever met. So just letting you know, our students love you. They also want to hear more about what are some of the challenges you face as a Black woman in this profession? Have you, since you've dealt with discrimination and racism, how have you handled it? And what advice do you have for students experiencing the same? Sorry, long question.
No, you're fine. The story I'll tell is one that I put in my book, and it's basically learn to play the game. And I would work really hard. I'd come in early, I'd round, and I'd do all the things I was supposed to be doing, right, to be part of this. And then what I found out was on Saturday mornings, the guys were getting up and going to play golf. And so I didn't know this, and I just learned to sort of play golf. I don't play golf very well. My husband plays golf very well. But one of the other faculty members that was sort of a mentor, he basically said, so why are you not playing golf? And I was like, what are you talking about? And he's like, all the guys are going to play golf. You don't even show up. And they basically were talking about that you didn't care to come in. No one had offered. No one ever told me. And so learning to play the game of medicine was also learning the politics, and that was more of a situation where people may not have seen it as sexist, but it was definitely because I was totally excluded. But by God, the next couple of weeks I showed up. I was out there with the 7 a.m. tea time, to be part of the team and let them know, even if I did not hit a ball and nor get a putt, I played the game to be part of that. So I chose not to react in a way that was going to harm myself. You don't cut off, your arm, to spike the body. You just want to make sure that you're getting what you want. And so what I realized in several situations, and I won't discuss all of those, was if I choose to react a certain way, even though I was totally within my means of doing that, would either get me fired or basically were going to make my life harder. And by all means, there was not going to be another Black female orthopedic to come through that program after me. So in several moments, I chose to stay calm, pick your battles, and then decide how to respond so it's to your benefit.
Gotcha. Wow. You're just such a strong woman. I'm just so inspired. How are you able to find mentors that you can relate to in your field, since this is a dominantly white male field?
So, and I did not have one. I had mostly white males that were my mentors. I had one, Dr. Ronald Lindsay. He was the acting chair. He's now the chair at UTMB in Galveston. He spoke up for me. He stood up for me. He basically was definitely trying to diversify orthopedics, and specifically at Baylor, to make sure that he's like, you're going to be the first Black female orthopod at Baylor College of Medicine. That's huge. That's historic. And, it was because he stood up for me, not necessarily because I had the greatest credentials. I interviewed better than most and was probably the harder worker though, and so therefore all things are weighed in with your application is another great point there. I had another great mentor. He was hilarious. He would come to bat for me. He would stick up for me, that kind of thing. So it was that, but I never saw a Black female orthopod. In the first year that I ever did, I was a third year, I believe. I went to a conference called the Ruth Jackson Orthopedic Society, which is the first woman in orthopedics. And so it's a whole society. And there was a woman there. She was one of the first 10 Black females. And so unbeknownst to me, I didn't realize there was thousands of us in America. I thought there were thousands of us. I just didn't know. I just thought this program that there was just the first. But come to find out, I was the first Black female in Texas. And I think in the top 30 as far as the ones in the country.
Oh,
So
wow.
we call ourselves the Black Diamonds, not because we're Black, but it's very rare. It's very resilient. And it takes a lot to find one, but very, very expensive also.
Well, I'm glad our students now have you to look up to as well for if they choose to follow this field. Do you have any advice for students like you who don't have a lot of mentors or people they can relate to in orthopedics? Do you have any advice on how they can find these mentors?
So the other thing is, like, a mentor doesn't always have to be someone medical. And I think this is something you should definitely understand. It's great to have someone that's in the field that you want to go into because they can know the ins and outs. But sometimes a mentor is someone that can help direct you when you don't know what to do or how to do it. So I would tell someone, in trying to find a mentor, you want to be committed to saying, okay, is it okay that I call you once a month, or we email, or we set up a meeting time? When you're talking to that mentor, you basically find out, who they are, what they're doing, as well as how they can impact you. They want to know how they can help you. Is that advice? Is that, trying to find you a job? What is that? And so you have to do your part when you're asking for a mentor. I think social media is a huge avenue right now, you guys. You guys are on another plane that I never had in finding people. So today, literally, I had 5 people, 2 on Twitter and 3 on Instagram, that found me. They were like, can you mentor me, or can you give me some advice, or is there somebody that can mentor me, that kind of thing. So you can find programs that have mentorship like this, as well as if you're going to approach somebody on social media and, in their DM, make sure you know what you're going after and you've done your research, because if you come half-ass, usually that's what you're going to get.
Gotcha. What has been some of your biggest motivators to keep you pushing and get to your position that you have now?
Ooh, great question. Failure.
Okay.
Failure is the greatest motivator, instigator to keep you going, to redirect you, and also make you appreciate and have more passion for what you're doing. So I always tell people, embrace failure, because it creates character, it creates substance in who you are, but also it makes you want it more.
True. All right, less serious questions. Would you say that an orthopedic surgeon needs a lot of physical strength?
Yes and no. I mean, I've got some.
Oh, heck yeah.
Dr. Salazar, what you think? Yeah, that's an ER. Is that an ER?
Those are pretty good.
That is a serious bicep.
Serious bicep. Yeah, I do some lifting, that kind of thing. But for the most part, it's technique. I always tell my patients, I had a general, 5-star general, come in. He had a hip dislocation. He looked at me, he's like 6'4", and he looked at me and he says, "You and what arm is going to put this hip back in?" And I was like, "Me, a little Ativan, Demerol, and Propofol. You're going down," So his wife videotaped it. And so basically she was like, "I can't wait to show him. I can't wait to show him. Here's this, small little black doctor that's standing over him. Pop the shoulder in and pull up, and it pops right in." So when he comes to, he's like, "I told you you weren't getting back in." I said, "So you're going home. Have a wonderful night. I'll see you next week in clinic." And so it's like, enough drugs, enough relaxation, perfect technique. You can do this. You can do this.
Sonia, I wish you could see this. Technique greater than strength. Love that.
Always. For even some of our smaller residents, just seeing them so confident after reducing a shoulder, for example, it's all about technique, and they feel like, wow, it's actually doable. It's like, yeah, it's all about technique. A little bit of muscle, good. Technique, even better.
No, that's right.
Wow. So maybe, you know, me and my twig arms can do
You can do it.
orthopedics one day.
Yeah,
Maybe.
you can do it. You can do it.
Right. Rachel, I don't know about that. You got little bitty arms. I don't know.
Yeah. Selena Poon is smaller than her. She was the one that came after me. Selena Poon, she's
right.
actually orthopeds in California. She's awesome.
All right. Maybe one more question, Rachel.
Yes. So a couple of our students were curious, how do neurosurgeons and orthopedic surgeons handle the spine differently?
Technique. Yeah. So a lot of neurosurgery is more fine, and they're going to make smaller incisions. Sometimes they'll make smaller incisions. Definitely they deal more with the brain and spinal cord and nerves, that kind of thing. Or orthopods deal more with the bone itself. So patient comes in that has a spinal stenosis, we're more likely to, you know, release the stenosis, which is the tightening of bone around the nerve as it comes out. Here's my bone pin. So, you know, the bone and the nerve is coming out. We're likely to go in and open that up and then fuse the two bones together. Whereas neurosurgery may do a keyhole incision and just release very small amount. So it's really technique more than anything else.
Gotcha. Now, I think our students would love to hear a day in your life.
A day in my life? Oh, here we go. You ready? So for me, if I am not traveling, let's just say, or if I'm traveling, I'm being an orthopod, it starts with early meditation. I actually do get up and do some meditation and some praying, and usually stretching, especially if I've done something heavy or the day before, do some stretching. And then you basically want to go into the clinic. So clinic looks like reviewing x-rays, reviewing charts, dealing with complicated patients like little kids that want to put things down their cast. And then even in surgery, you know, you still have to show compassion and good bedside manner. So for the most part, clinic may be, bless you, you know, 10 to 20 patients on the Navajo Nation. I've been other places we've had up to 30 patients in clinic. So depending on if they're follow-up or if this is a first-time fracture, or, you know, are they needing a cast and x-rays, it depends on the time. So most patients come in, they get seen by the nurse. Pre-COVID, let's talk about that. Pre-COVID, seen by the nurse, get roomed, usually have them change clothes so we can do a good examination, get a great history. So you're asking them, you know, what happened, all the details of what happened, because it makes a difference in maybe how I treat them. And then they either going to get, orthopods only have a couple of things, you guys. Either we're going to do rest, we're going to ice it, we're going to do some type of compression if that's a brace or a cast, elevate it, you know, if it's a sprain or a strain or whatever else, or if it's broken, we're going to have to either splint it, reduce it, and or operate on it. So I hate to tell you, that's pretty much all we got. That's our whole arsenal, you know. So that keeps things simple though when patients come in. You know, there's some complex things that you have to worry about, but for the most part, dealing with x-rays, this is probably the only field that you have to learn two fields. You have to know orthopedics, but you also have to know radiology, because I look at x-rays, I look at MRIs, I look at CT scans. And so in my book, I talk about trust no one, partly because you're responsible. So even I have to review all those things, even though a radiologist may have said, you know, the bone is broken here, but how I look at it and what is broken, how it's broken is different than what a radiologist says. So two different jobs, you really do. Part of our clinic, our ER, looks like casting materials and splints. Most of this stuff is in the ER. You never see that much material in the ER, especially like a Indian Health Service, or maybe even at Parkland. It's usually probably locked up or behind keys, glass at a drawer, or bars or whatever else. You have to have a key. Usually the nurse in the ER has the key to get to the materials, you know, that kind of thing. But this is splint material that we need to reduce and or put a cast on, that kind of thing.
So Sonia, an orthopedist friend of mine, Mercer Bridges, who's now passed away, once said to me, you see what you see, meaning the emergency docs, on x-ray. It's always worse than that when you get into the patient at the time of surgery. Could you comment about that?
Yeah, so like and you'll appreciate this. So, it's an ankle fracture. They have a bimal ankle fracture. So for you guys that don't know, I don't have an x-ray on here, ankle. I'll show you in a minute, I believe. So the ankle has two sides to it. And so both sides can break. And usually it's a pretty simple surgery. But then when we get to the ER, It's like, oh, well, it's actually sublux or dislocated, so you have to put it back on. And then you get to the OR and we didn't get a CT scan. It's really not an ankle fracture, but it's a tibia. We call it pylon fracture, which are treated totally different. You wait time because of swelling and that kind of stuff. It's a different type of fixation device that we use and that kind of thing. So you really want to know what you have before you go into surgery. So yeah, and the ER says, okay, we got the x-ray, I'm like, well, can we get a CT scan? And they're like, really? Can you just come in and see the patient and just put the damn splint on? And you know, that's what most ER docs are gonna say, Dr. Fowler, Dr. Salazar, but I digress.
No, that's so important. So do you find sometimes that you want to go further in the pre-op evaluation than perhaps others have done before when you get the patient?
I do, because I want to be sure that I'm sure, but also I want to do it in the ER because by the time they get up to the floor, it's not going to get done in a timely fashion. So if it's done in the ER, I can do it in a faster, way. So I can get all the images I want. I usually have more hands to help with, that kind of stuff. But if they get to the floor, if they admit it and get to the floor, it's over, man. It's like, no. But for pre-op planning, that kind of stuff, get more x-rays, definitely.
And that inevitably clashes with us.
I know.
Well, no, in a positive way, but only in as much as, the ER is full. We're trying to turn the bed over, trying to get them in, get them out. You're going to admit them anyway. Well, can't you get the damn scan up on the floor? And you're saying, no, actually things work faster by doing it in the ER.
Yeah, for the patient and me. But also during COVID, this whole thing during COVID has been a whole change in how we deal with medicine in the ER. At the Navajo Nation on the Indian reservation where I'm at, we basically have 2 gigantic tents in the ER parking lot that are our makeshift trauma rooms, basically. And so patients don't even get to the hospital before they've had the COVID test, and respiratories on board, and everyone's in full PPE gear and, all that kind of stuff. So then once they've at least been cleared from that stage, then they're going to go to a PUI or, patient under investigation for COVID floor. And so they're treated differently. They're going to go, they're trying to make sure that if they have to have CT because they're a trauma patient, then CT is closed down until terminal cleaning, right? Because there's only one there. So everything is done differently. It's slower pace. We've turned away a lot of more patients because we just couldn't handle the volume, the load on top of COVID and the trauma, so it's just different now. Medicine is practiced differently, totally. Yeah.
Thank you. Keep going, please.
All right, so let's go to the OR. So you get dressed, you got to put your scrubs on, you got your scrub hat, you're gonna have gloves. Now with COVID, we actually do our helmet that has basically the spacesuit vibe, that we can have an air pack. I still wear it N95. These were pre-COVID pictures that you're looking at here. You have an assistant in the OR with you. And that is actually the guy on the left is Dow. He actually died of COVID, 32 years old. Was one of my surgery techs. Loved the guy, huge, always would help me even reduce things that if I couldn't get it reduced because he was so big, so strength played in with some stuff. But for the most part, you have anesthesia at the head of the table. So you can see the patient actually has like a tube here. That's they're intubated and breathing here. Usually have a circulator that's going around the room, that's making sure whatever you need, you have, that kind of thing. And then we have music in the background, we have snacks, and I'm just like, we do have music usually going on. So it's dealer's choice, either anesthesia or ortho, depending on who has the better music that day. And then you sort of see my tools, my playground over here. This was actually for a hip replacement. Reamer, drill, pins, skin rake, mallet, or hammer, some soft tissue stuff, retractor for soft tissue here. So when you go to the OR, it's a whole event. It's another world. And when it comes to orthopedics has so many pieces and moving parts to it. You can have a huge table on the back, what we call the back table, and multiple trays, multiple sets of different things. Just for one ankle, we may have 2 different trays. There's a locking plate and multiple screws on top of cannulated screws. So it's a lot. It's a lot that goes on in the OR, but orthopedics is so much fun. You take a broken bone, put some metal in, use some power tools, and you fix it, and they make you better and leave you alone. They go away. It's not like medicine where hypertension, diabetes, You know, these things you don't ever really fix. So this is why I like orthopedics. You get to go to the OR, fix them, and send them on their way. So let's do our first surgery, if you will. So this patient was 82-year-old female, really interesting, right proximal humerus. Proximal means the top. Humerus is the arm bone, if you will. She actually had got a brand new stove, electric stove in her kitchen, and I guess her husband decided to hook it up. Now, what's next to the stove in most houses, at least I was in Louisiana at this time? The sink. And she took her iron skillet, one hand, and put it into the water in the sink, and her new electric stove that was not grounded sent a bolt of electricity through her arm and out her shoulder, tore up her rotator cuff and blasted her bone. Interesting. One of the best fractures I've ever seen and got to treat.
Wait a minute. So she didn't fall on her elbow. It was something else. She hyper rotated her shoulder, or what?
When she fell down, she fell directly on it with the blow. But part of what you can see on the actual incision, that hole that you're looking at, was part of her rotator cuff had been burned and tore during the actual electrical shock.
What an unusual injury.
Yes, it was amazing. But nonetheless, we put a locking plate on. This is a locking plate, proximal locking plate, and all these screws. And you can see the outline of the bone here. So it was a great surgery, though. And then she did well afterwards. You know, put her in a sling.
Could you comment about the second, the middle photograph?
Uh-huh.
She's got pretty good thickness of her cortex. Her bones are pretty healthy.
Her bones are great for 82-year-old. Yeah, look at that. Awesome.
Could you point out what the cortex means and the relationship to the strength of the bone, please?
Yeah, so cortex, can you guys see my arrow?
Yes, ma'am.
Okay.
We see it.
So the cortex is this thin outer shell. So think of an egg. It would be the outside. It would be the cortex. The inside, we consider cancellous bone, is softer and a little bit more porous, if you will. So as people get older and have osteopenia or less bone, what happens is this cortex, or the outside part of the bone, becomes thinner and easier to break. And so these are things we look at when we're trying to fix the bone as well, as can it hold a titanium plate and all these screws? And so that gets into some of the technique of the different types of implants we use. This is a locking plate. It will not, the bone will probably fail before this plate fails, because it's that kind of construct and locks into the bone and the plate. So it's actually really cool. So proximal humerus fracture. Great case. So how long do most ortho cases last? It just depends on how bad the fracture is. You could be doing like a carpal tunnel surgery, you know, small incision here, you go and you release and you're done in 10 minutes, you know, or you could be doing a big intertroch, you know, proximal femur fracture that just getting it reduced is going to take almost 30 minutes in the OR before you even make an incision to start putting a rod in. Or you can have a very complex pelvic surgery and trauma, cases that can take 6 to 8 hours, you know. But usually if it's a long bone, like a leg or something like that, that we're going to put a tourniquet on, you want to try to limit like under 2.5 hours because of blood supply to that limb. So we're very, very careful about that kind of stuff. So cases last different times. You can be on your feet for long, long hours. You can be sitting down doing cases. Hand cases, most the hand surgeons sit. Pediatric cases, most of them sit. Spine cases, you're standing. Pelvic cases, you're standing. Joint replacements, you're standing for long periods of time. But again, it just varies, different things. All right. So what's the average day? Even if I'm contracted and I'm working, the average day is 8 to 14 hours. When I'm there, I'm on call 24/7. So my day doesn't really stop. So I'm going to get calls at 1 o'clock, 2 o'clock in the morning from different parts of the reservation about grandma that fell and, you know, has a distal radius fracture, and they want to splint her and send her in because, you know, they didn't get it reduced well, that kind of stuff. But on a good day, yeah, easy 6 to 8 hours that you could, you know, get out of clinic and be done with your dictations and your rounds. That kind of thing. But typically on average, a 10 to 12 hour day, easily. easily. And that's going to consist of your clinic. That's going to consist of ER coverage. That's going to consist of OR, going to surgery. Some surgeons will pick a day that we go to surgery. You know, some people want to do a Monday, Tuesday, so people are out of the hospital by Wednesday or Thursday. Some people do, I do Wednesday cases. So most of my cases are small and they're done with or whatever. But if a case comes in over the weekend, you just have to do it. You know, you'd rather do it earlier than later is other things. So our cases usually start very early.
So Sonia, how often do you find that you have to bring in a surgeon of another specialty on a case? I guess in multi-system trauma, of course, you may do that.
Well, usually with pelvic, I won't do pelvic trauma or spine. I will ship out. I can stabilize it, you know, but I'm not opening up and doing an acetabular, which is like a hip socket. I'm not going to do that. That's more of a trauma related and then long-term. And so the hospital that I'm at specifically, again, it's a tertiary, you know, level 3 trauma that we shouldn't be doing some of the trauma that we do. But when you're 2 hours from Albuquerque and there's nobody on a, you know, near to you, you're it. You've got to be able to take care of it, stabilize it, and fix it. So we still operate almost as a level 1 trauma most times.
So Sonia, I remember back in the 80s, 30 years ago, I was working at a suburban hospital in my hometown, and at 4 o'clock in the morning on a Sunday, I was the only doctor in the hospital. And if something happened, deliver a baby or, you know, start a central line or whatever, yeah, I would have to handle that.
Yeah.
So I would ask you, at what point did you find in your career that if there was something in your field that you would be able to handle that? When did you finally get there?
That I could handle it all, you mean, basically?
Yes, exactly.
It was probably my second year in practice. You know, and I realized how great my training was. It was a orthoped. He had proximal femur, distal femur, tib fib, open ankle. He had proximal humerus. It was one of those, you know.
Oh my goodness.
Broken man.
But he jumped off a building, or what did he do?
He was motorcycle accident.
Yeah.
The donor cycles, yeah. But he survived. He survived, and it was tedious and multiple surgeries. But at that point, it was an accomplishment that I knew I could pretty much take care of or handle anything, you know?
I remember we would have to deliver babies. And I remember I got called up one night to the OB floor. I must have been 27 years old. And they said, Dr. Fowler, you need to come right in there. I said, what's the problem? He says, well, the baby's coming. I go, yeah, what? It said, the foot's coming out. So the first baby I delivered was a footling breech. And it was
my gosh, that's horrible.
And you know, you ultimately as physicians, we get thrown into, at some point we get thrown into it, and we just have to handle it, you know?
You do. And that's the confidence side, I think, that you learn. And a lot of that will come with where you train and the confidence that's built in by your staff members, your faculty, even the residents that are around you, how they build your sense of confidence in what you're doing. And speaking of foot, you're showing
us a terrible trimalar fracture here.
Yeah, this was the one I told you they should have got the CT scan on, and we didn't, and took it to surgery, and it was a bit more hard to reduce and get it stabilized than I should have had a CT, you know. But when you're in it, you just have to fix it and know how to take care of it. You know, it was not reducing well, and couldn't figure out why. Well, there was like definitely a piece that was in the joint that I had to open up a little bit more to get it reduced. So this is considered a tibia, your shin bone, your fibula. This is the smaller bone on the side, on the outside of the leg. This piece is actually the lateral part of your ankle. If you go down to your ankle joint, you can feel on the outside of your ankle. This is called the lateral malleolus. The tibia has a piece that comes down called the medial malleolus, medial meaning the inside of the leg or the ankle joint. And this is the talus, or the top part of the ankle. All of this should be over here. All of this should be over here. One more time. All of this should be over here. This shadow piece is the piece that was stuck in the joint that you couldn't really appreciate. But nonetheless, put a plate on. This is a locking plate that basically we put in. So that means the screws actually lock into the plate itself and the bone. This is considered a syndesmosis screw. Syndesmosis is the ligament, a very, very strong ligament between the tibia and the fibula that basically spans the whole joint. If it's torn, it basically makes the two bones unstable. So you have to stabilize that with a longer screw that heals. And then the medial malleolus piece, this fragment here, we basically put a couple screws in to line that back up. And so this is the AP, anterior to posterior, front to back view. And this is the lateral or the side view. So you can see the plate and the screws end on, and the other screws here.
So Sonia, does the metal ever come out, or it just stays there?
I usually leave it unless they're very, very young. The syndesmosis screw can come out because what has happened over time is that syndesmosis ligament heals, it will break the screw. So you can get this part out, but you'll never be able to get that part out. So sometimes I will remove this single screw. And then in younger patients, I will sometimes go back and remove the plate and the screws. But remember, you're leaving holes, so therefore they're still going to have to be non-weight bearing for like another month while that heals in from those screw holes.
Dr. Sloan, may I ask a question? One of the things that you said to me that was really inspiring, and I hope our pre-healths with us tonight take it to heart, is that sometimes you get thrown in situations like Dr. Fowler said, and you have to do something, take care of the patient, and the reaction should always be not like, nope, this is not me. Yeah. Send somebody else. The reaction should be, how can I help? As much as you possibly can. One of the things that Dr. Fowler and I see on a regular basis are patients who have surgeries like this or bad fractures like this. They come to us, they don't have insurance or the funds available, often with very complex surgeries like that. How do you navigate those waters should you get a patient who comes in with a very bad fracture like this, or after a surgery like this, and they don't have the funds, insurance, follow-up to take care of their injury?
I think there's two things. There's a liability that you have now laid eyes on this patient, and you know that they have a draining wound, that there's an infection that you now are privy to. So therefore, it's almost like malpractice that you don't take care of someone that now has the possibility of having osteomyelitis, osteobone myelitis, infection of the bone. And so therefore, yeah, you're somewhat obligated. And if not, help find someone that can take care of them. And so in the ER specifically, a lot of times I'm trying to, hi, sweetheart. A lot of times it's not just me taking care of the patients, is help, how do we get them transferred out? And that means me talking to the orthopod there, or me talking to the ER doc at the level 1 trauma of why this patient needs to come there, that kind of thing. On the money side, I happen to be at the Indian Health Services, so that's not an issue. Like, they pretty much take care of their own regardless. And definitely in a trauma situation, that. But if the patient is a non-pay or out of pocket and or out of network, I think the business side of medicine either is handled by someone else, but if it's you and you're trying to take care of this patient, it's like, can you make a wager of saying, how much can you pay? Or, how can we set this up at a later time or whatever else? And if they really just say that I don't have it and I can't do it, then at some point that human nature of just doing what's right, I think, comes back into play, just comes back into play.
Sonia, in the middle of surgery, do you ever find yourself wrestling with what might be a cheaper way to do a procedure? Does that ever enter your mind? I can say at Parkland it doesn't. I don't think it does. Gil, you could.
It does with the population that I deal with, the indigent patient population, for two reasons. A lot of times they don't want surgery. The Navajos are very superstitious to having implants in their bodies, metal. As well as they don't want someone cutting on them. That is considered bad energy or bad, medicine for them. So they would rather not. And so how can I help them honor their, what they believe and their traditions and that kind of stuff, but at the same time still take care of them? Dr. Fowler, I have literally, I want it more than two hands. The number of patients I've literally given almost a death sentence to because the family didn't want surgery,
Interesting.
Excuse me.
And clear your throat. Go back to your left-hand picture there. Bless you. Go back to your left-hand picture there and point out how the tibia is displaced from the talus, and the fact that this is a terrible injury. The tibia, the shin bone there, actually sits on top of the talus. And so this is a complete disruption of the joint. It's a terrible injury. And you could kind of sort of push everything back where it belongs and hope it's going to heal, but it would be a desperately unstable
It was.
joint that you could not walk on. Plus the complications, infection, it could be an open wound,
Right.
plus infection, not to mention phlebitis, the deep vein thrombosis that might develop and so forth.
Yeah. And so a lot of them are not compliant as well, because even though we operated on this lady, she walked on her cast.
Oh my goodness.
But
Oh no.
So she did have some wound breakdown, and so then we're putting a wound vac on and trying to take care of that. And so,
Oh my
you know,
word.
it's medicine is also a joint effort. You've got to get your patients buy-in, because if they don't believe or they're part of this, you're taking care of part of the problem, but the rest of it is on them for the healing process. You know?
Sonia, multiple students have written, how did that initial injury on the left occur? Was it motorcycle or a fall, or what was it? Do you happen to remember?
Okay, are you guys ready for this? She fell off of the bar stool at the casino.
How did you do a tri-mal falling off a bar stool?
I guess it was a high bar stool. I'm not sure how she fell and twisted it. She was diabetic, so her sensation was poor. She didn't realize it was that bad.
Oh my goodness. Did
Yeah.
she at least win the bet, I hope?
No, I don't think so.
Oh, good gracious.
Yeah, it was a bad injury. It came together nicely. So what else do orthopods do? What else can you do with this orthopod? So I've told you guys that I started part-time. What else do? I lecture. I do travel. I lecture to minority students. This is Howard University in Washington, D.C. And this was specifically the medical school students. And we talked that day specifically about the journey of medicine and having passion and being a leader, because at no point really do you learn about leadership, but most of the time people will think that you're a leader just because you have doctor behind your name. And so we talked about some of those things as well. I do a lot of blogs. I write for different articles, different companies, and writing blogs, and I do get paid for those blogs, about between $400 to $600 a blog, depending on the word count. So I do everything from orthopedics to racial issues. This recent one was one about dealing with racism right around the George Floyd issues that were going on. And then I'm part of the Black Women Orthopedic Surgeons organization, and we do a lot of mentoring. So we're mentoring the next generation of orthopods, but we're a great support group to each other as well. I am a first lady of a church. My husband is a senior pastor of the Luke Church here in North Houston. We have about 6,000 members in our church. Pre-COVID was 2 services, usually sometimes 3. And we had a huge children's church as well. I helped build the health ministry there, as well as navigate the ins and outs of just loving on people and being compassionate and bringing the spiritual side into medicine as well. You guys can see I'm a mom of 3. I have 2 teenage girls. This was last year's Christmas picture. So I have 2 teenage girls and my son. And then I started Sloan STEM in 2017. We had our first full camp in 2018. 2019, we had over 150 Black students, specifically kindergarten through 8th grade. We did robotics, we did programming, engineering, you name it, we did it. Science, technology, medicine, and the arts portion came in with audiovisual and instruments, painting and that kind of stuff as well. So one of the last things I'm really, really proud of is our church was affiliated with an organization in Haiti called New Missions. And I helped raise the first $75,000 to build a medical clinic there in Haiti on the Legon Plateau that services about 100,000 men and women and children in a year. So it's mostly primary care, prenatal care, sexually transmitted diseases, and minor cuts, scratches and bruises and small fractures, that kind of thing.
So Sonia, were you always an outspoken person, or is this something that came later, or
I believe
as your mission became clear?
I think I've always been an outspoken person. I think at this point in life, it's about, for me, legacy living. Like what I'm doing has to matter, you know, like time is of the essence. And if nothing else during this period of COVID, everything has to matter because we just don't know. We have no idea. So it has to matter.
that's beautiful. Time is of the essence. What a beautiful thing to say.
Thank you. Thank you. So these are the things you can do outside of that. I did write a book recently. This was my pay it forward. It's called The Rules of Medicine, A Medical Professional's Guide to Success. And it was basically, my mom was a nurse, and she was, rule number 4 was know the janitor's name. And it was basically about respect and understanding there's certain things that are said and done in medicine that we know about, or we may say it, but no one really ever explains these things to you, but you need to know that will help you be successful. I talk about rule number 1, trust no one. Trust was more of the factor of the x-rays, the labs, all those things I needed to look at to be able to take care of my patient, but also understand that we're very competitive by nature. And so the plastic surgeon that was wanting to go to surgery that day, and I'm the ortho surgeon that wanted to go to surgery that day, we were in general surgery rotation. He did whatever he could to undermine me to make sure he was at the operating table and not myself. So it was a lesson learned that we're still competitive. So understand that as well. Rule 34, the last chapter in the book, is about pay it forward. It is the coming back and giving back to the next generation that is going to be the ones taking care of me, that may be taking care of my children, that make sure that they've learned the things that I either got wrong and or can make a difference to make the world a better place. So that's the pay it forward.
So Sonia, let me see if I understand you, because you've got over 500 kids listening to you live at this moment. You're telling me that these kids, as they develop and then toward later on in their careers, that they really need to be obliged to help engage the ones that are going to come after them, to help prepare for the next generation? Is that what you're saying?
You are duty bound. You are obligated. That if you go through this course of what we call medicine, traditional medicine in America, you are obligated by all means to help the next generation, because they're going to be the generation taking care of you or your children. So you got to pay it forward.
185,000% agree. This is all about paying it forward. This is exactly what it is. It's not a pipeline, it's a path.
A path.
So Sonia, at least the experience of old physicians is not worth anything, because all the new information coming out is going to erase the past. Is that right?
I don't know. I think there's still some great. I'm in that generation of I'm not new, but I'm not old either. But I believe that there's a mixture of all of it. But we've got to be able to leave behind enough for them to understand, to navigate, to do better. Definitely.
There's no question. Yeah, no question. I was playing with you just a little bit, because I distinctly believe that there's stuff that we learn at the bedside, especially in emergency medicine, our field, the abdominal pains, the chest pains, the headaches, that the history taking, for example, and our examination techniques, some of it may be replaced with artificial or assisted intelligence over time, but I don't think a lot of what we do is ever going to be replaced. And thus, when you say pay it forward, we're going to continue to hand that forward to the generation that comes after.
You better believe it. You better believe it.
I think it's true.
Yep.
Keep going. Keep going. I'm going to order your book. I just wrote it down.
That's all I got. That's all I got.
Oh, what a wonderful talk. Rachel, let's take it away. Let's do a last QA for this wonderful guest.
Our students, so many of our students have just bought your book, just letting you know.
Thank you guys.
And they're so amazed, and I'm amazed about you doing so many things. You're an author, you're a philanthropist, active in your community. How have you been able to stay active in your community and interest while practicing medicine?
And that was the lifestyle. So there was no way that I could do this and be the full-time orthopod making $700,000. There was not. What I know that I have a different calling in my life, that mine is about impact, of how I can influence other people. My nonprofit for motivating and empowering women to excel is the entrepreneur side. Before I got into medical school, I had a coffee house, so I learned a lot on the business side and understanding how that translates, not just into medicine, but for other people that just needed to know, how do you start a business? How do you become successful? Medicine is a business, don't get me wrong. But lifestyle, I had to pick and choose what I wanted. And I've been pretty good about cherry picking, you know, what I wanted to do, how I wanted to do it on my terms. And that's a blessing. Not everybody can do that.
Absolutely.
So Sonia, you have chosen to stay involved with others from your coffee house as a pre-med to your nonprofit foundation and your church work and your clinical work. What you have chosen to do is to make interpersonal contact an element of your life, that it's being part of the lives of others cannot be separated from who you are.
And not just being a part of it, but how can I make their lives better?
That's wonderful. Rachel, please.
Yes. As the field is constantly evolving, how do you stay up to date with the new techniques and research in orthopedics?
Definitely with online stuff. So, I mean, the apps are wonderful. So like the American Medical Association has, you know, a great app. The American Academy of Orthopedic Surgeries has a great app. So that with your CMEs, which is your continuing medical education, it's that. I do a lot of reading on other things. I'm really interested in the technology side of medicine and AI and cryptocurrency and blockchain and medicine and that kind of stuff. So I sort of pick and choose what I want to read about and stay abreast on, but definitely your continuing medical education, you know, I stay up on orthopedic things on that level. And realistically, to be perfectly honest, it's like medicine just cycles, you know, it comes back. It's like what we did before is now coming back around 20, 25 years again, you know? So they may change, they may fluctuate, but guess what? Eventually it comes back to some common sense, as well as some things we've always done.
How is it like doing orthopedics virtually / through telemedicine?
Spiritually through what?
Virtually or through telemedicine?
So when I bought into this company several years ago, telemedicine was on the cusp. It was just now starting and coming up. So it was better in primary care stuff. And I remember saying back in 2017, I think it was, I said, eventually telemedicine is going to become the triage of medicine. And it's because you can do things with telemedicine that can keep people out of an ER, out of your clinic, you know, out of the hospital. So less overhead, less people working, that kind of stuff, which is totally advantageous to any corporate insurance or whatever else. They want to see the dollar signs come down. So I saw that a long time ago and sort of got involved. It's harder for subspecialties. So orthopedics is still evolving as far as telemedicine goes. I can get on the patients that I usually deal with. I want a second opinion. So these are patients that have already gone to an orthopod and they've told them they need surgery and they just want someone to talk to them, take some time to really explain to them and also discuss options if they were not comfortable with that doctor or that kind of thing. I have patients that, you know, come on and they have their kid and their elbow it's a nursemaid injury and they just want to know, you know, do they need to go in at 11 o'clock at night versus can this wait until in the morning, you know, that kind of stuff. We have patients that are post-op. I just want to be able to see the incision, make sure it's not red, hot, or swollen, and that, you know, they can now get it wet or whatever else. So that kind of stuff through physical therapy. Telemedicine and orthopedics is now involved because you can actually bill for the telemedicine post-operatively if they're with the physical therapist and you're monitoring what they're doing. So there's different avenues and it's going to grow. I was part of TEDMed a couple of years ago, and the technology that's coming down the pike that will be associated with our phone, all the way down to a freaking x-ray eventually is coming, you know? So I think telemedicine is going to grow. It's going to change. It's not going away now that COVID is here, you know, and we've seen it evolve enormously. So it's definitely something to embrace and adapt. Gotcha.
How has your spirituality play a role in what you do professionally?
Huge, huge, huge. There's a chapter in my book that says miracles do happen. You know, it's the unexpected. It's we are not God. We are not sovereign by ourselves. And that we can know medicine, you can know textbook, you can know all that, but there's I call it the faith factor, the God factor, the whatever. There's something that, you know, we're just paintbrushes in this life, the mere strokes of the artwork of the human body. And that, you know, we get to play a part of it, but you're not the ultimate say, you know. So understanding a higher power, a higher being within yourself is one thing. Respecting that in someone else is a whole nother ballgame. And that will change your bedside manner, and how you deal with patients, how you take care of patients, how you deal with losses, grief, trauma, drama, all of that. But it's a balance. I think your spirituality is a balance. And I'm not talking just church. There's a difference in spirituality in your church or your synagogue or your mosque or your temple. There's something different. And that's your spiritual being of who you are, your essence of who you are. And that has to be nurtured. That's the self-care of medicine that we are now getting back to, self-care.
Beautifully said. A lot of our students want to know, what is the most common procedure that you perform?
That freaking ankle fracture. I think it depends on where you are. It really does. I probably deal with more ankle fractures, injuries, and saw, because the population that I'm with, the Navajo, they do a lot of wood cutting. So I have a lot of chainsaw injuries, finger injuries, and that kind of thing. And even animal injuries. I mean, I had a wrist dislocation because the patient got her hand stuck in the wool of the sheep that ran off, and she fell and broke her wrist. Not in Houston, Texas, you wouldn't have that, but on the Navajo reservation, you do, that kind of stuff. So it just varies.
Some of the students want to know, what do you do on the Navajo Nation? Like, what kind of things do you see?
Okay, so it's basically desert. You're in the desert pretty much. There's some mountain ranges, beautiful landscape. If you've ever seen a New Mexico sunset, you got to see one. Just the sand in the sky is just beautiful, fabulous. But it's very desolate. It's very poor. They are very no funds. So what you see is a very destitute people, and that really do value care and good care. But you can have the reservation on one side of the street, train tracks, the other side of the street is Walmart and Starbucks and Sonic and McDonald's, and so that doesn't lend to their healthy living by no means. But so that dichotomy of reservation, hogans, which is their housing where they live, a hogan usually has a wood burning stove in the middle of the house, and it's almost like an octangular shape. And usually it's multi-generational homes. Like there may be 3 families living in that. So no running water. Usually most of the bathrooms are outhouses still. If they have the luxury of having a trailer from the government and having a bathroom, you have stairs, you have dirt that basically becomes muddy, that kind of stuff when it rains, which it doesn't rain a lot there, but when it does, it's bad, or ices and snows. So they're dealing with conditions of weather, lifestyle, and poverty. They really do. So it's a very poor place. But what you do see is the resilience of family. They are a population of people that believe in supporting their community and their tribe. I mean, nothing that we see, what we understand or know. It's on another level, and I do respect that.
I'm so glad that they have an amazing provider there like you to help them out and treat them. Last question. Our students want to know, how closely do you work with other specialties? I know you mentioned anesthesiology, and also other healthcare professionals like PAs or nurses. How close do you work with them? So
part of the Pay It Forward is also understanding the hierarchy. I talk about that in my book as well. I call it the totem pole, not because of who you are, but it's the level of your training. So the totem pole is about knowing where you are in this hierarchy of medicine, because a medical student won't know how to do a total knee replacement, but the resident may. And so with that learning, that education, you gain more knowledge, you gain more respect, and you gain respect on the level of your practitioners, to the nursing staff, to the OR staff, to the freaking pharmacists, you know what I mean? But it comes back to know the janitor's name. It's about respect. If I respect and I treat you how I want to be treated, those people will meet you where you are and sometimes go above and beyond for you, because you see them as a human being and not just as a title.
Beautifully said. Thank you so much. Oh, sorry,
Sonia,
Dr.
what a wonderful talk. Thank you so much. This was just, you had 600 people sitting on the edges of their chairs listening to every word. What a terrific talk you gave. Just marvelous. And let's everybody put a thank you Dr. Sloan into the chat so she can see your warm wishes. Rachel, you're going to tell us about how, look at the chat. It's just blowing up with thank yous. Rachel, you're going to tell them how to do the assessment?
Yes. So assessment 44, you can take your phone and scan this QR code or visit our website or check your emails tomorrow or our Instagram for the link to the assessment. You have until next week, so right before our next session at 6:59 p.m. Central Standard Time to complete the assessment and get your certificate. Please, please, please click that certificate button or else you do not get credit for this session. You have approximately a week and I hope y'all do well on it.
Questions aren't hard.
Yeah.
Thank you, Rachel. Sonia, we're so grateful to have had you with us this evening. You had 600 students sitting on the edges of their chairs. We typically in our sessions will have about 5,000 that will actually view the sessions out of the 44 that we've seen. So we've had over 210,000 viewings. Each of the 5,000 folks that view the sessions as pre-health providers will in their career probably see about 100,000 patients. 5,000 times 100,000 is 500 million. So tonight, Sonia, with your wonderful talk and your great humanity and your warmth and your honesty, you've touched 500 million lives tonight. So,
that gives me chills. It gives me chills.
So thank you so much. And so we're so grateful to have you here. And all of you, if you keep coming back, we're going to be here. So just let us know that you want us to keep doing this. And so on behalf of the whole virtual shadowing team and Dr. Sloan and Dr. Salazar and all the rest, we want to thank you for joining us tonight. We've got all these, yes, please keep doing it. So, coming back, we're going to be here. So on behalf of the whole virtual shadowing team and Dr. Sloan, we wish you a good evening and a good night.
Good evening. Thank you, guys. Thank you so much.
Bye-bye.